Welcome, everyone. I'm Dr. Tara Kieran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted that our department can continue to bring these sessions to you together with the Ontario College of Family Physicians. And I'm looking forward to introducing Mekalai, who is going to introduce the session from the OCFP. She's the new president-elect. Mekalai?
Thank you, Tara. Good morning, everyone. I'm really pleased to be here. My name is Mekalai Kumanan. I'm the president-elect of the OCFP. We have a really informative session planned for you today, and I'd like to just start by thanking our panelists and thanking all of you for being here. Brief reminder that this is a Maine Pro accredited session, and further details will be sent to you via email. Next slide. So I'd like to say the land acknowledgement. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP respects that Indigenous peoples have a rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And today I'm calling in from the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the neutral peoples.
Thank you, Mekalai. Go to the next slide. Indigenous and Black people in Canada have vastly different histories, but at the same time, they both share a history of trauma. And in this collective trauma, one of the results of it, of course, has been mistrust, really, irrational mistrust of government, and in some cases, vaccine hesitancy. And I just wanted to draw your attention to this terrific framework that was pulled together by some of our colleagues, including Anya Norum, that you can use to support patients when you're having discussions about vaccines and you still are receiving hesitancy. The Ontario Medical Association worked with Anya, the Black Physicians Association of Ontario, as well as the Indigenous lead at U of T, Chase McMurrin, who actually to produce these set of videos. And Chase is an Indigenous physician who is in the videos as a physician interviewing and counseling a Black patient. And I think it's quite a powerful show of allyship, as well as a demonstration of a clear demonstration of kind of the way in which you should have a conversation. So this is a members only kind of link, but if you put in your password, you should be able to see the whole full page as well as those videos. Next slide. So as usual, our conversations are building off one another. If you've missed our previous sessions, please do check them out at our website. A reminder that today's recording will also be available at the website. It should be available by the end of the day. We'll post the slides as well as a summary of the Q&A. The Q&A takes a few more days for us to post because our great team summarizes that. Next slide. So delighted to welcome a terrific panel today, and I'm going to turn it over to them one by one to introduce themselves. Next slide. Allison.
Good morning, everyone. My name is Allison McGeer, and I'm an adult infectious disease physician at Sinai Health System, doing work on the epidemiology and prevention of COVID. As you can see, I have relationships with many of the vaccine and antiviral manufacturers for COVID.
Kate.
Good morning. I'm Kate Miller. I'm a family doctor coming to you today from the luxurious physician call room at Listowel Memorial Hospital, where I practice emergency medicine and I do family medicine and obstetrics in Guelph. I'm also a member of the Ontario Science Advisory Table's Clinical Practice Guideline Working Group, so have some intellectual conflict there potentially, as I'm going to be presenting our guidelines today. Financially, only Spinker honoraria from the college for this talk today.
I love that you're calling in literally from the trenches, Kate. David.
Hi, I'm just on my cell phone at the moment because I had to reset the intranet at my office. It was unstable. Best laid plans. So I'm David Kaplan. I'm a family doctor calling in from my clinical office. I'm the Vice President of Quality at Ontario Health, where I receive salary support, and I receive an honoraria from the Ontario College of Family Physicians.
Mekalai?
Hi there, my name is Mekalai Kumanan. I'm a family physician. I practice in Cambridge. I do sit on the Echo Chronic Pain and Rheumatology Advisory Board, which does not pose a conflict for today's session. And I do receive a stipend from the OCFP for some work I've done on their virtual care working group and our COVID task force.
I'm Dr. Tara Kieran, and I've listed my conflicts on the slide. Most are research and salary support that I've received. Only 2 are for for-profit companies that don't pose a conflict for today's talk. Next slide. So as usual, you guys are a big part of what makes this community of practice really sing. We want to get your questions and do our best to answer them. So please put your questions in the Q&A box. And remember that I'm going to prioritize the questions that get the most thumbs up. So instead of putting in your own question worded a little bit differently, if someone else has already asked a question that you like, give it a thumbs up. So I'll prioritize answering the most Q&A questions with a thumbs up. Please use the chat not for questions, but if you want to share resources, reactions, network with others, the chat is a wonderful device for that. Next slide. As usual, we have a lot on today's plate, and I'm just going to go through a brief agenda of what we're going to cover. We're going to start with Allison talking about what our future holds. What can are we in a pandemic? What does that even mean? We're then going to just cover some of the latest evidence around vaccines, the new Made in Canada vaccine, the latest evidence on 4th doses, and the latest evidence on vaccination in teens and kids. We're then going to switch gears and go more towards therapeutics, and Kate's going to give us an update on the new Ontario Science Table guidance around therapeutics, the updated guidance, and then we're going to talk about how to implement that in your practice, and David Kaplan is going to give us an update on the COVID clinical assessment centers, as well as speak from a systems lens around what our primary care priorities should be in this time as we move in from a post-Omicron phase. And lastly, we're going to just get a poll from you guys around what you need to support yourselves as we go into this recovery phase so that the Ontario College can better advocate for your needs. Next slide. So without further ado, I'm going to turn it over to to Allison to get us started.
Hi, everyone. Okay, so we're talking about where we're going. I think there's 2 pieces to this, short-term and long-term. And there's 2 issues to worry about in the short term. At the moment, case numbers are stable or going down, hospitalizations and the ICU admissions are going down, and generally speaking, cases are going down globally, so everything is looking good. The things that are worrying people a little bit anyway are, first of all, the emergence of BA2. BA2 has a substantial number of mutations from BA1. It does not look different in terms of severity of disease. It does not look different in terms of vaccine protection. But the fact that it's taking over from BA1 in many places is an indication that it is more transmissible than BA1. And if it's more transmissible than BA1, then you would think that cases should go up. And so this is just because we don't have a good graph for Ontario. This is the graph for the United Kingdom. You can see the green starting at the beginning of December is Omicron going from 0 to 90% in about 3 weeks. And BA2 is taking over more slowly. By the middle of February, BA2 was about 25% in the UK. Ontario's a little behind that. It looks like at the end of February, we're about 25%. So there's good news and bad news here, okay? BA2 is definitely taking over, but so far we haven't seen the expected increase of cases, and neither have Denmark or the UK where these are starting. So BA2 is still to watch and to worry about a little bit, but it doesn't seem to be turning into the additional cases that we were worried about. Next slide. And then the question is, what's going to happen now that we've substantially released restrictions? And again, things are kind of looking stable. So this week compared to last week, cases are up for the first time in about 8 weeks, but only by 10 cases out of 2,000. Okay, so really small tinge up. Test positivity again up for the first time, but only by 0.2%, still running at less than 10%. If you look on the left-hand side of this slide, you can see that overall in Ontario, the wastewater signal is also trending up a little bit. We don't have quantitation of what that means and what that kind of increase means. And if you look on the right-hand side, also from the Ontario Science Table here, you can see that the number of COVID cases now looks like it's stabilizing a little bit as opposed to going down. So remember, of course, that we just discontinued a whole lot of precautions earlier this week. And because we're not looking at cases anymore, we're looking at hospitalizations. Our ability to judge what's happening is 2 or 3 weeks delayed. So there is going to be this 3-week period where all of us will be sitting a little bit on tenterhooks, hoping that the release in restrictions is being adequately balanced by the increase in third dose vaccinations, and that people are holding on to their masking and their distancing enough that we will slide through March. And then as the weather gets better and we get outside, things will settle down. But there's still a substantial amount of uncertainty about what's going to happen to cases in the short term. Okay, longer term, next slide. We're talking about moving to endemic. This is a little bit frustrating because epidemic and endemic are not quantitative terms. They're words we tend to throw around. If you use the literal translation, epi means on people and en means in people. So if you think about the pandemic as having originally come upon us, when we get to the stage where disease rates are low enough that we live with it and go on with our normal lives, so think seasonal flu, that'll be when it becomes endemic, but it's a slow process to get there. So there's a number of things that might happen over the next few years, and this is my version of what people think the range of possibilities are. So the top scenario on this is the best possible case, okay? Omicron is here, we're not gonna get new variants, we're gonna get maybe a slow change in the virus, but all coronaviruses do that. We'll have durable vaccine immunity. Either third doses are going to hold for severe disease, or we'll need a dose or two of new vaccines, maybe in the fall. Our antivirals are going to stay effective, and there's a whole stack of new antivirals in clinical trials now. So, maybe we'll be okay. And probably not next year. Next year, activity will probably still be measurable and important, but the year after that, COVID will just be a seasonal coronavirus, okay? Causes colds, we all get to ignore it. That's probably a better scenario than what is actually going to exist. What I think people are, it's a little bit hard to tell how much this is wishful thinking, but I think people think that scenario 2 is probably what's going to happen. That there will be ongoing emergence of variants, that probably COVID will settle into being a winter seasonal disease in temperate climates, that will need annual vaccines, that will have to change them over time like flu vaccines, and that the activity level will be variable like influenza. So some years will be bad and some years will not be bad. And in bad years, seasons may stress the healthcare system. And if we're really unlucky and we get flu and COVID at the same time, and both are bad years, then maybe we'll even have to go back to some masking and some restrictions to save the healthcare system. This scenario kind of bleeds into the next scenario, which is the pessimistic scenario, which says that this is going to be worse than influenza. And part of the reason it's going to be worse is because it's not going to be seasonal. So new variants may arise, but they can arise kind of at any time, sort of like Omicron, Delta, okay, they happen in the middle of the summer. Then we'll have to adjust what we're doing and adjust new vaccines. Some variants may have significantly greater severity. We tend to tell the story that when new viruses come, they get less severe over time. That's not necessarily true. So there may still be variability. And we don't know how this virus is going to respond to antivirals. So we might get much more antiviral resistance. So we might end up with something, at least until enough of us have had repeated infections, that is more painful than regular seasonal influenza. And then at the bottom, there's a list of worst case scenarios, all of which are plausible for coronaviruses, okay? So nobody thinks these are likely to happen, but all of them might. We know this is a zoonotic disease, so mice and deer and hamsters and all sorts of other mammals get infection. It looks like birds can get SARS-CoV-2 as well. And so we could get, like flu pandemics, we could get recurrent coronavirus pandemics from reintroduced virus or from recombination of viruses. The UK already has a Delta and Omicron combination now. Coronaviruses can also change their tissue tropism. So if they feel like it, they can stop being a respiratory virus and become a peritonitis virus or something else. Again, not likely, but possible. And they may be able to continue to have antigenic escape, and it could actually get worse than Omicron. We could theoretically end up with a situation where your second infection is worse than your first infection. This is what happens in dengue fever, because you make antibody, you prime your immune system, but you prime your immune system in the wrong direction. So when you get your second infection, your immune system goes off on a tangent, doesn't deal with this new variable virus as well as it would have in the first place, and you get sicker. So nobody is really seriously thinking about these worst case scenarios, but it does mean that those of us who are doing pandemic planning, those of us who are worried about epi, those of us who are developing vaccines still really need to stay focused so that if one of these worst case scenarios starts to appear, we're ready for it. Okay, now a couple of better things to talk about. Next slide. This week, first licensing of a Canadian-made vaccine. So this is a company actually owned by Japanese investors, but it's in Montreal called Mekalai. I'm not sure I'm fond of their vaccine name, Covafens. It's made in plants. And what you do is you take the spike protein, you incorporate it into a bacteria which infects the plants. You get the plants to take up this bacteria. And normally when they take up this bacteria grows and creates cankers. In this situation, you use the bacteria to persuade the plants to make spike protein. And when they make it, it comes out surrounded by lipids. So you get spike protein in little lipid nanoparticles that look kind of like tiny viruses. And you can use that as a vaccine. Purify those viral-like particles, and then it's adjuvanted with the adjuvant from GSK, the same adjuvant that was in the pandemic H1N1 vaccine in 2009. So this is a non-live virus, got no genetic material in it, it's fridge stable. The only slightly irritating thing about it is it's supplied in 10-dose vials. And so what you get is 2 vials, an adjuvant vial and a vaccine vial, and you have to mix them, and then you have to use your 10 doses within 6 hours when you get them. But still a lot easier to handle than the mRNA vaccines. This vaccine was 75% effective against any infection in clinical trials, which looks a little lower than the other vaccines, but could have been because they were looking really hard for mild infections. It still may be very useful. There are no data yet on using it as a booster dose, so we'll have to wait for that to come. And there's not going to be supply of it probably until sometime in May. But now we've got 2 protein vaccines that will be available in the next few months, Novavax and Mekalai. So this is good progress on the vaccine front. Next slide. And then lastly, quick note about 4th doses. There's 3 sets of evidence on what 4th doses do for you. First of them is from Ontario long-term care residents. You definitely get dramatic increases in neutralizing antibody in these residents after their 4th dose. And just this week, Sarah Buchan and Jeff Kwong presented ISIS data that was developed for the Ontario Immunization Advisory Committee, looking at the comparative efficacy of 4th dose to 3rd dose in long-term care residents, and protection against any infection was 47%, against symptomatic infection 63%, against severe infection, 49%. And you look at that and say that it doesn't look like it's going in the right direction. But the truth is, if you look at these confidence limits are relatively wide. So the walk away from this is that there is substantial protection in residents of long-term care. As you might expect, it's not as good as the first dose against nothing, but it's still a good reason to be continuing fourth doses in long-term care. There's initial data from Pfizer in adults over 60 from January. And there, the vaccine efficacy, again, fourth dose compared to third dose, 50% reduction in any infection, 77% reduction in hospitalization or death. And those numbers explain why the FDA is looking at fourth doses for older adults, and we might well be too, if we start to see cases going up. What we're hoping at the moment is that cases are going to go down and we can avoid recommending additional boosters beyond the third dose recommendation, at least until the fall, so that we can get a good boost in the fall. But we're going to have to see what happens. And then finally, there's a study from Gili Ragievyoke's group in Israel with randomized controlled trial of Moderna or Pfizer for a relatively small number of healthcare workers. These healthcare workers were getting screened twice a week. Okay, so when you say any infection, it's like really any infection. Most of them were completely asymptomatic. They did get some boost in antibodies, but it wasn't dramatic. And their estimate of protection against symptomatic infection was about 30%, which is relatively small. So unlikely that we're going to be thinking about recommending fourth doses to anybody under 60 for the foreseeable future. Thanks very much, Tara. We'll turn it over now.
Thanks so much, Allison. I'm going to actually just pick up on that last point you just made, because I think it answers one of the top questions we have. So Terry Weinberg has asked, if our booster shot wanes at 6 months just after the mask mandate's likely to be lifted, do you have any advice? So I think some healthcare workers are worried about that.
Yeah. So the first important thing to remember is that protection against serious disease is still holding up really well. That's the critical thing to watch. As long as our protection against serious disease is up at 90%, if we're losing some protection against milder disease, that's not so bad. But you're absolutely right. It's on the list of things we're watching. If we get a case surge with BA2, if we start to see further waning of protection, then we may well be talking about introducing fourth doses, probably starting at over 60 and then maybe moving it slowly down if things start to wane. So we're exactly where we were in the fall again with second doses. We're watching what's happening carefully. If protection starts to wane significantly, we'll need to move to boosters.
Thanks, Allison. I'm going to actually go to slide 35, and Olivia, you're going to put that up, and because I think that a number of top questions that we have really relate to what family doctors should be doing in their offices to protect themselves and their patients, given where we are in the pandemic and also the loosening of restrictions more broadly. So, for example, Martina Rabsel says, should patient masking continue in physician offices once the province lifts its mask mandates? And so, David, I saw that you responded and said yes. And I wonder, David, if you wanted to speak to that orally, and if any other panelists.
Yeah, I think, I think there's an easy ethical argument for most of us as healthcare workers to understand. If patients or if citizens want to go to a restaurant or go to a theater and make an individual choice that they want to go somewhere where people may be unmasked, that's one thing. But when people have to seek care right now in a healthcare facility, they don't make a choice to need to seek care. And I think we have an ethical duty, never mind whether or not you want to call it a legal duty, but an ethical duty to make sure that the place that they're seeking care is the safest possible. And so for now, the mandate drop wouldn't apply to what we would think is best practice in a healthcare facility to protect vulnerable patients.
And just to build on that, there are a few other questions that relate to it. So Salwa Azar says, can we put patients closer together in the waiting room now that no vaccine passports or capacity limits are there in restaurants? And Cindy Goebel says, should we still be actively screening patients on entry to the clinic? So there's masks, screening, waiting room. And Mekalai, I noticed you also answered some of those questions. I wonder if you wanted to speak to that.
Sure. Yeah. So I can just review briefly the PPE and IPAC recommendations. And I think to David's point, we really need to continue to do our part to keep our patients safe when they come to see us, recognizing that we are seeing some really vulnerable patients. So if we are providing direct care to patients with suspected or confirmed COVID, the recommendation would be to use a fit tested N95 mask or equivalent. So that could include a non-fit tested N95 or a KN95 or a well-fitted surgical mask. And other PPE should include gown, gloves, and eye protection. When we are looking at our IPAC measures, and this follows the screening question, so it really is based on the patient's screen status. So for our patients who screen negative, we would continue with our standard cleaning processes that we were doing pre-pandemic. For patients who screen positive, we are being asked to disinfect any patient contact surfaces and then clean and disinfect any treatment areas or equipment that have been used on the patient. So that screening piece certainly impacts what we do in the office from a cleaning standpoint.
Thanks, Mekalai. I don't know if Kate or Allison, you wanted to chime in there to those series of questions. So Allison, I will say that the other kinds of questions we're getting relate to kind of the policy decisions that the government has made. So Terry Weinberger says, can you please explain the science behind Saskatoon's decision to advise individuals with active COVID that they don't need to self-isolate and they can go to work even when sick with COVID? And I think Patricia Hannon is, what's going to happen to our numbers now that we're going to withdraw public safety measures. And I think you answered that last one. So yeah, I don't know if you have if you wanted to chime in on that question from Terry.
Well, I think we've been on this roller coaster before. When cases start to get better, everybody is so desperate to get out of this that there's a huge amount of political pressure to remove restrictions. And somehow people talk them into the fact that, if things are going to be okay because they're going in the right direction, they forget that it's the public health restrictions substantially that are still protecting us. And so it's a belief system, I think, because you can't bear to think about anything else. And because somehow when things are getting better, you forget that the virus is actually in charge of the pandemic and we're just reacting to it. But things clearly are getting better. And for the first time, it's possible that, Saskatchewan is not going to get into serious trouble. The cases in Denmark and the UK are still coming down. They're much higher than ours at the moment, but they're still coming down despite the fact that public restrictions have been released. So, releasing some public health restrictions is definitely a good idea. We can do that. It's just a question of whether we have gone too far again and have to walk back a little bit, or whether, we're going to be able to just slide through. And a piece of that, as David points out, is about how we as individuals, as opposed to the government, reacts. People are, despite a lot of rules being lifted, doesn't mean that people aren't going to continue wearing masks, doesn't mean that people aren't going to continue to maintain some kind of social distance, doesn't mean that we're not all going to choose where we're using up our risk, as opposed to just like going out and doing everything again. And to the extent that each of us maintains distancing and precautions, then we reduce transmission. So it's fragile everywhere for the next little while, but it might be okay.
Thanks, Allison, for that. So I'm going to go back to our panel, our sort of agenda, and ask Kate to, walk us through some of the latest evidence around vaccines in teens and kids. I know that there were some questions about that as well, so hopefully this will answer them.
Yeah, so sort of picking up from Allison's review of where we're at with adults, teens, just a reminder, Ontario health regulation guidelines say all teens are eligible for a booster starting 3 months after their primary series. This is actually considerably more access than the NACI recommendations, which is still that it can be offered, so not even strongly recommended, but offered to high-risk teens starting at a 6-month interval. So there's a little bit of a disconnect there, both in terms of the who and when. And a part of that's because teens produce a much better response to the vaccine. So we're optimistic that they're going to maintain efficacy longer. 2 sets of data come out fairly recently that are actually a little bit counter to each other in terms of whether we can be relying on that primary series in a teen. So ICES data here in Ontario shows preserved vaccine efficacy after the primary series of the mid-80s for populations even over 180 days or 6 months from their primary series. So would suggest that a teen in that case does not necessarily need a booster or doesn't need an earlier booster. There's also some data that came out in Maternity and Mortality Review Weekly last week, which shows vaccine efficacy, in this case, looking at an ER urgent care visit during the Omicron wave in 16 and 17-year-olds, which showed a no protection from that endpoint at the 6-month mark, 34%. And 81% of boosted. So this data would suggest that boosters are important for teens at the 6-month and beyond mark. So I think what we do with that in terms of decision making with our patients is certainly as our teens get to 6 months, which many of the early adopters are, encouraging them to access that booster regardless of risk. And certainly the higher risk teens with risk factors or immune compromise, really encouraging that booster a little bit earlier. Next slide, please. So going down in age, we're talking about 5 and 11-year-olds. So this one was in the news this past week. So big headline that was really maybe more headline than story that came from the study that was in the medRxiv. So a preprint, not a peer-reviewed study, looking at effectiveness of the vaccine in both teens and the 5 to 11 age range in New York. Relatively small numbers, but showed a decreased vaccine efficacy at the December 13th and time point and the January 30th. So 6 weeks apart during the Omicron wave. Remembering that the children in the US got vaccine a little bit earlier. So they started their vaccine rollout at Halloween. And that in the US, it was universally a 21-day interval. So these will mostly represent kids with a really short interval between vaccines. And they showed a drop in vaccine efficacy from 68% for clinical infection down to 11% over that 6-week period, a drop from 100% to 48% over that 6-week period for hospitalization. They also pulled out the subgroup who didn't get their vaccine series until late November, early December, so the very newly vaccinated, and still saw a comparable drop to those who had been vaccinated earlier. These are really small numbers, though, and during a time when data collection is really difficult, so testing there, just like here, has not been universal. So really hard to know how robust this data is. And then if we can just bring up the next piece, because this compares to, so next slide, there we go, compares to data in that Maternal and Mortality Weekly report, which did not show a comparable drop in efficacy over that 6-week time period. So one set of data saying maybe it drops, the other not, and also much bigger numbers in the second set. Next slide. And so this is just the ICIS data visually represented for both of those age groups. And you can see that vaccine efficacy over the population for the older age groups, the 11 to 17 group, so those are the lines that you see at the top, really well preserved. Some drop in the younger age groups, and then that fits with what we've seen, which is higher hospitalizations in children over the month of January. Next slide. So lastly, what about the under 5s, right? Because I think there's been lots of eagerness to see this population vaccinated. Certainly as we ease restrictions and protections, families with children under 5 are really, really anxious about the fact that society will not be protecting their children and that vaccine is not available to them. Unfortunately, I don't have a lot of certainty to report here. Pfizer had its initial data for their 2-dose, 3 microgram schedule available in early early December, and at that time did not release their data, but released that there was insufficiently robust protection for the 2 to 5 age range. It was actually sufficiently robust, whatever that means, for the 6-month to 24-month age range, but they elected not to proceed with approval at that time, but instead created a 3-dose vaccination for that age population, with that data becoming available either this month or early next. Moderna also has a study that will soon be wrapping up, looking at 2 doses of 25 micrograms, so much higher dosing than the Pfizer dosing. So if the Pfizer lack of response is because they underdosed, hopefully Moderna will show that a higher dose is available. And that data is also expected sometime later this month. So earliest we're looking at approvals for the under 5s is kind of May timeline, although I think most predictions are later than that. Into scenarios will be times of low enough cases that we're not as worried. So potentially, hopefully we'll have something for this age population if we see a fall wave. And I think the message overall from all of this data is that for everyone, regardless of your age, you're probably going to need more than 2 vaccines. We're probably going to need boosters at some interval of some kind, and that this is going to be kind of continue to be evolving advice and evidence. Next slide.
Thanks so much, Kate. I'm just going to pause before we go into therapeutics and just see if there's any other panelists who wanted to jump in here. I don't know, Allison, if you wanted to comment on any of the issues related to teens, where we've gotten quite a lot of questions. And I think that's something that people are struggling with a little bit.
Yeah, I think everybody's struggling with 3rd doses for teens, because I think the general sense is that 3rd doses for teens are a greater benefit than a risk, but there's still a lot of uncertainty about it. So, in that setting, what you're hearing from NACI and the Ontario Advisory Committee is we're not so confident that there's a big improvement that we're saying every teen should get it. But we also know that the risks are low and that COVID is bad. And so nobody's feeling in a position of sufficient confidence to say to people, you can't get your teenager, if you are a teenager, you can't get vaccinated because we said so, and it's not recommended. So that permissiveness is marking a substantial degree of uncertainty about just what the size of the benefit of the 3rd vaccine dose is, and about whether there's some benefit in waiting for boosting later when you might want it versus boosting earlier. And so there is, I think the consensus is that 3rd doses are a good idea for teenagers, but not such a good idea that it's required. And if people choose to wait to have their 3rd dose, as Kate says, we're all going to get to a 3rd dose eventually, okay? Just a question of what and when, but it doesn't mean you have to do it now.
Yeah, so I mean, I think lots of different perspectives, which are good and healthy, and good for us to have this discussion in those gray areas. So Kate, I'm going to turn it back to you now to just take us through the latest on the therapeutics. I know you've been on the working group, and thanks to you and others who've been really had your head deep into the evidence and are helping all of us navigate that.
Yeah, so new set of guidelines in late February, sort of building on those that came out in late January. This is definitely, we recognize that this has changed often and that has created some confusion and difficulty keeping up. However, the landscape keeps changing. So not huge differences really in the latest guideline in terms of what drugs and for who. Some small changes in strength of recommendation because we got some published data for Paxlovid, and also some changes in the recommendations because at the moment our supply of drugs is quite good. So we've got an increase in our access to both Paxlovid and Sotrovimab at a time when our demand for those drugs are going down. Although there is some concern that particularly with Paxlovid, our supply has not been accessed to the extent that case levels should indicate. So we know that there's a challenge in getting the people who would benefit to these drugs, getting them to the drug. And I'll talk a little bit to that. Another change is around pregnancy. So initially we had put a contraindication on Paxlovid, precautionary with pregnancy, but further review, evidence, and recommendations from some major organizations such as the American College of Obstetrician and Gynecologists made us feel that that contraindication could come off because there was no proven or theoretical fears around harm in the risk framework. Next slide, please. So the reason that we could change the risk framework was because of data such as this. So this is data from BC. We have some comparable data from Alberta as well that really allows us to tease out and add in some nuance. So if you remember with the most recent, the previous guidelines, tier 1 and tier 2, really kind of big chunks. Age, immunization status, that was about it. We can now pull out the difference between someone who is unimmunized, partially immunized, and boosted. We can also pull out from the data the difference between someone who might have one risk factor or multiple risk factors. And we knew with the previous set of sort of risk groups that we were missing some people, for instance, in the younger age groups who were high risk because of multiple comorbidities, and potentially worrying a little too much about some of the older people who are well protected with a booster. This heat map just shows that the more risk conditions you get, the older you get, and the fewer doses of vaccine that you have, the higher your risk of hospitalization. But applying something like this is a little too complicated, so we tried to simplify it down. Next slide, please. So now your risk framework really is looking at three things. What is the patient's age? How many doses of vaccine have they had? And how many of the risks that you see listed below the chart do they have? So if we take, for instance, a 52-year-old woman with diabetes, hypertension, and obesity, she's had her primary series, but she's not yet had a booster. What we would do is go to the 40 to age 69 age band. We would move across to the column of 1 to 2 doses and look to see, is she standard risk or is she higher risk? And because she has risk factors, she would be higher risk. If we take that same patient and only have one risk factor, for instance, she would not be. Or that same patient who's had a booster, so 3 risk factors but boosted, goes into the standard risk category. So you're doing age band, dosage band, and risk factors. The patients who are listed as higher risk are people who have a 5% risk of hospitalization and will therefore benefit from the therapies which are targeted at that population. And the people in the standard risk category are below 5% and therefore at this time would not be qualified for or therapeutics be recommended. As always, this data is based on a mix of data of Delta with Omicron. We're looking at across the range of things, but that's true of our evidence for the therapeutics as well. So we're always having to look a little backwards at the data and recognize that we won't know what's the perfect thing to do today until sometime in the past. 2 other special populations over and above that, they get treated a little bit differently, just as before. The immunocompromised, so those who would not be expected to mount a response to vaccination or infection, qualify for therapeutics regardless of vaccination status and other risks. And also pregnancy. So the unimmunized pregnant person has about a 7% risk of hospitalization. So they would also qualify for therapeutics as higher risk, even in the absence of other risk factors or at a younger age. Next slide, please. We get some questions about what the standard risk, and it's because of this part. So below the graph and the recommendations, you'll see on our executive summary that for standard risk, the thing with strong evidence, or the green circle, is reassurance, information, and self-monitoring. But fluvoxamine and budesonide remain there. So for the higher risk individuals, you would only be considering fluvoxamine or budesonide if you cannot access the other therapeutics for whatever reason. They're still here under standard risk. And I've had a number of questions to say, does that mean we should be offering these to everyone who is at standard risk? Does that mean we should be talking to every single person who gets COVID about therapeutics? And no, what they're here for is to recognize that there are some patients who are not going to fall into that highest risk category, but they might come close, right? So 2 risk factors instead of 3, they're 39 instead of 40. So they're really close to perhaps a risk band. A patient that you're really kind of concerned about their risk of severe disease that may not qualify for Paxlovid or Sotrovimab, but you feel like that we really should be doing something for that patient. Fluvoxamine does not not have great evidence, but there is some evidence with an NNT of about 30, 35 to reduce hospitalization. So you might consider offering it for that. Budesonide, the evidence really isn't about reducing severe disease and hospitalization, but is better for reduction in symptomology, particularly respiratory symptoms. So for any patient who's at higher risk of persistent respiratory symptoms, you might think about offering high dose budesonide. Next slide, please. So lastly, there's one of the sort of things is that while we've tried to make it simpler, we've tried to make a simple graph, some people are still going to have trouble stepping through that. In places like BC, they actually have a patient calculator online where you can, as a patient, go in and see whether you qualify and put in your risk. We don't have anything like that here in Ontario, but Sohal Goyal, a family doctor in Mississauga, has created this Google form, which you could share with your patients or use yourself to sort of put through and try and figure out what band is this patient higher risk or lower risk. And so it really just goes through those steps that I outlined and would then spit out, yes, you qualify, no, you don't qualify. Next slide, please. And then lastly, we've really had a lot of, as I said, a really low uptake, particularly of Paxlovid. It has not been dispensed far as much as one would expect based on our cases and our population. And I think a lot of that is about knowledge around access, and particularly among our patients, right? Our messaging has been at the provincial level, you don't need a test, you don't need to be seen, just stay home, which doesn't really work when we have drugs that need to be administered early, within 5 days for Paxlovid and within 7 days for Sotrovimab. And so while the ideal for this would be a big public education push on the provincial level, in the absence of that, we're looking locally in your practice about how can you help your patients who might qualify for this? Can you be proactive with your communication? Should you be reaching out over to them through email or through websites, or kind of how do you let patients know before they even get infected? Hey, if you get infected, I want to hear from you. Make sure you know what your local landscape is. So in some places, getting a CAC assessment is hard, but in a lot of communities, it's not. So certainly in my community, if you need to be seen at the CAC, you can be seen today. So knowing where the fastest access to assessment and decision-making in your community is important. And then remembering that these patients aren't phoning us directly, right? They're talking to our office staff. So are our office staff, who are those sort of managing the phones, do they know who they should be highlighting and where they should be directing patients? Do you have a protocol and a script for your staff so that if someone calls in with COVID, they can quickly figure out, is this a patient who might need urgent assessment today? And what's our local process for that urgent assessment, whether it's a virtual assessment with you or one of your colleagues, or a referral to the CAC. And then I think the last thing is these guidelines make us a little nervous. Like, what if I think they qualify, but what if they don't? Or maybe they don't qualify, but maybe they do. Like, don't worry if you're over referring into this system. If you think they're on the borderline and you're not entirely confident, send off that referral to your local Paxlovid site. Let them sort it out for you. If you are worried that their drug interactions maybe mean they can't have Paxlovid, rather than deciding that they not to refer them, let the pharmacist at the Paxlovid site do that assessment for you. And then I think the other thing to remember is that this is a rapidly changing landscape, and we will be moving towards general prescribing. So BC went to general prescribing of Paxlovid on Monday of this week. So now any primary care provider can write a prescription for Paxlovid. Most of our centers that are doing Paxlovid are using a virtual model. So they're assessing the patient by phone and having the medications couriered to them across some pretty wide distances. So, you might have your meds sent from London all the way up to the tip of the Bruce Peninsula in Tobermory. And I'm aware of at least one Paxlovid site that is already allowing community providers where you're confident that they meet the criteria and not worried about drug interactions to actually be writing that script themselves and dispensing it without anyone at the CAC doing a direct assessment. The Ontario Science Advisory Table has a new updated what patients and providers, or pardon me, pharmacists and providers need to know document with the drug interactions. So if you need to look that up and are thinking of prescribing it yourself, there's some really good evidence within that document to help you step through, do I need to worry about medications or not? And recognize that both your local pharmacist and the pharmacist at the CAC site can really help out with that.
Thanks so much, Kate. I think, you've walked us through the new guidance, but it's also clear that clinical judgment still continues to be really important, and that we have these drugs and they're to some degree being underused, and we need to support our patients to contact us, triage them appropriately, or send them right to the CAC so they can do that. I think you presented some great evidence from BC that influenced the guidance. And I think Diana Ahmed just pointed out that those hospitalizations are based on Delta and not Omicron. And so that, there's lots of evolving evidence there as well. And I think Harry O'Halloran asked, is there real world data about Paxlovid? Others are asking, do we know how people have tolerated it? I don't know if you have any comments on some of those, Kate.
Real world published data I'm not aware of yet, although anecdotally appears to be holding up from the study evidence. It is pretty good study evidence in terms of the number and the robustness of the study, although predominantly within Delta and unvaccinated population. But that, again, just going to reiterate, that's true of all our therapeutics. We're making decisions always in the rearview mirror. From a tolerance standpoint, it is relatively well tolerated. The most common side effects are an unusual or bad taste in the mouth, although you can get that from COVID too, as well as nausea and diarrhea. So really the bigger challenges with Paxlovid is not side effects and a patient's ability to tolerate it. It is more around the drug interactions that happen because of the ritonavir, and some complexity in sorting out dose in those populations, as well as those with renal failure. I think the other thing to remember about the guidance is that this is Paxlovid or Sotrovimab, and we are not recommending one over the other because there is no good head-to-head data that tells us one is better than the other. So the choice for the patient really is about what they can access. So if they're day 6, Sotrovimab is a better choice because Paxlovid, we only have data up to day 5, although I suspect data up to day 7 will come for it. There's certainly certain populations such as pregnancy we're more comfortable with Sotrovimab just because it's been used more. But really the choice of which of those two drugs is about who your patient is, where they are, and what they can get within their context.
Thanks, Kate. So we're just going to keep going on this trajectory and go to the next slide. Just to highlight a few other resources. So this is a handout on the Confused About COVID site that Kate helped with, as well as a number of others like Noah Ivers and others. And it really summarizes kind of what's out there for patients. So if this is a great add-on to any letter that you might be sending out to your patients. And we'll be keeping it up to date because I think there are a couple of new conditions that we need to add on here that to reflect the latest changes. And so I think the key point here, as Kate said, is to tell people to call you if they are in any of those near those high risk areas. Next slide, or to call their CAC. There's also a number of educational sessions that do deeper dives on therapeutics. So this is a talk from the CAN COVID speaker series. And Alan Grill also posted in the chat a link to the recent CFPC webinar where Kate was also a panelist. Next slide. I'm going to actually turn it over to you though, David, because I think you're going to emphasize some of these similar messages around how are these COVID assessment centers working, how, I think Kate mentioned refer, and I think you're going to probably emphasize that. And I think others are also just mentioning that, how can we get this message to our office staff and support our office staff to be able to support patients?
Yeah, absolutely. Thank you so much, Tara. So maybe I can go to my first slide. Really, I think we've shown this before. This is really the reason that we set up clinical assessment centers to really take that test and treat approach. Lots of different inputs, including self-referral. So patients don't need to have a referral to go to a clinical assessment center. And really the idea is that they can get a clinical assessment and testing and a diagnosis. And then really what we're talking about today is directing them to or giving them outpatient therapeutics if they meet eligibility. Kate just went through the eligibility for the COVID-19 therapeutics. I think, the most important thing that we can do in our communities as family physicians is either working with our public health units, or if we know folks in the media and using the platforms that we have as clinicians, is getting the public message out that, don't stay at home if you think you are at risk for, hospitalization. And, many patients realize that they have multiple comorbidities, or I think it's one of those new words that most patients have learned over the course of the last 2 years is the word comorbidity. But if they're older, that they shouldn't just stay at home and self-isolate for 5 days, but we do need them to either call their primary care physician or actually just self-refer and go to the clinical assessment center. And so I think it's part of our advocacy role as family doctors to get that message out. And then obviously having an ability to make sure that if they do call our office, that we can triage them appropriately. That there's been some scripts created that I know has been shared both by the SGFP and the OMA and others that the team here at OH wrote with some help from some of the clinicians that have been on this COP before. And that's been a helpful script, I think, to make sure that patients get directed to a clinician when they call up so that we don't lose that 5-day window. Next slide. So from the primary care pathway, really, we want to be able to prioritize is really what I'm getting at, making sure that if a patient calls at 10 o'clock in the morning and you're not in, but one of your colleagues is in, that the front staff know that this is something that needs to possibly just get 5 minutes of someone's attention to see if they would qualify for therapy. And then you can see on this slide, there is that link to the script to help staff in identifying who those patients are. Or you could obviously use Dr. Goyle's tool to work through it individually, because the script is not perfect, but we did try to get it to a level that most staff medical office assistants could use. Next slide. Wanted to focus a bit about as we come out of this wave around priorities. You'll see here the first thing it really is to continue to focus on urgent and emergent care. And it says here to avoid unnecessary emergency department visits. We do know that there are many patients with ambulatory sensitive conditions that appropriately go to the emergency department. Like, we can't provide the care that they need in our offices, but really what we're talking about, and you'll see some examples in a minute, are the nature of things that we as family doctors and nurse practitioners often look after, where people do not need the level of care in an emergency department to have those needs met. Resuming or continuing preventative care services such as screening or diabetes screening. Just a word about the cancer screening. One of the approaches I've taken, so, I know that I have about 100 women in my practice that are now overdue for their pap smear. The majority of them are overdue because of the pandemic. So they may be overdue because of, they're 6 months out or 8 months out from being 3 years from their last pap. But really what I did, for instance, which I think is probably a good way to look at it from an equity approach, is I actually looked in my EMR to find out who are the ones who are overdue the most. And so I have about 25 women, who haven't had a pap smear since, I was just looking at it here, since 2016. And, I've decided I'm going to focus on that cohort of my patients, the ones who probably are at most risk of having a missed cervical lesion, as opposed to the ones who maybe just be a month or 2 or 6 months out from being overdue. We talked about the early identification and referral of patients who would benefit, and then obviously continuing all the work that we're doing around remote monitoring of COVID patients and supporting vaccination. The next slide shows a highlighting of an article that was written by our colleagues in Canadian Family Physician in 2017, and I only want to reference it because I know many of us do focus on things like cancer screening, and it's obviously extremely important. But the numbers needed to screen compared to seeing patients with a headache in your office or a patient with a gouty toe, the value of primary care is obviously in screening, but it's also in treating many of these acute conditions or patients with long-term symptomatic conditions. And so I do think it's, on us to sort of figure out, if we have a certain schedule, how do we, or amount of clinical time, better yet, in our office, or that we're devoting to our clinic, how do we balance all of these sort of different competing
common conditions and preventative interventions that we can do. And this is just to highlight sort of many of the different things that we would want to consider in trying to figure out how to carve out our time moving forward over the next number of months. And then the next slide, and I'll end here, really is just a comparison of benefit of different interventions that we do in primary care, and the numbers needed to screen, for instance. So, for cancer-specific mortality, the estimated benefit is you need to screen about 1,000 people, which is like the size of my practice, over 10 years. Whereas with acute symptoms, you need to treat 5 to have somebody benefit. So I think it is a balance. I think it's going to be up to us individually to figure out how do we manage our practices, but I don't think we can focus on one thing and not another. And this article by our colleagues in the CFP, I think, is a good example of how there are definitely competing demands in primary care.
Thanks so much, David. I love this article, so I was so happy that you showed it. I think it's always been a challenge how we prioritize our time in primary care, especially that we have this onslaught of like demand that comes in, acute demand, but then at the same time, there are people that are not calling in that we know we probably need to reach out to because, their needs are even greater. And then now there's the backlog issue that is on top of everything else. So thank you for highlighting that.
And I think if we heard that, folks wanted to dive deep into figuring out how do we use our EMRs to identify the people who have either never been screened or the people who are really overdue for their interventions, I think that's something that maybe we could do with our colleagues at Ontario MD and have a separate session for folks. Because I think, there is a lot of power there in people's EMR to figure out who these people are.
And so I want to also acknowledge a couple of comments, one in the Q&A and one in the chat that I think are alluding to the new Ontario Medical Association and government tentative physician services agreement, and that's going to be coming to vote with the membership. So there's some comments about that, and I'll say that's out of scope for our discussion today. We're not going to be talking about it, but absolutely encourage all of you as physicians to educate yourself about what's in that agreement, attend the sessions that I know are going to be happening with the OMA to get your questions answered, raise those concerns that you've raised today, and then cast your vote. That's really important. So we're not going to talk about that today, but of course it does influence the work that we do, how much we get paid for it, and what we think is valued. Next slide. I'm going to keep going to the next one after that. I wanted to now turn it over to Mekalai, because I know this idea of how we can support family doctors to recover is really important, and we wanted to get your input. So Mekalai, I'll turn it over to you.
Thank you. I'd like to just take a couple of minutes to maybe let you know about some of the work that we are doing behind the scenes at the OCFP. And I just want to reiterate, we know it's a really trying time in primary care. We know we are all struggling with our own backlog and also trying to navigate access and care for our patients in a system that is quite backlogged. So I think our first step is really wanting to ensure that we understand the supports that you need that will help you the most as you navigate the next few months. So maybe we'll start by going ahead with the poll. So the question here is, which 2 items would help you the most as you adapt your office for pandemic recovery?
So Olivia, can you please launch the poll? There we go. So everybody should be able to see that poll, regardless if you're on the phone or on your computer. And it would be great for us if you're able to just click the 2 items that you think would help you the most. We're going to give you about 30 seconds to do that. And this will directly inform the Ontario College and the priorities that they have. So again, take a look at that poll. There's talking about IPAC, screening, managing symptomatic patients. So some things that we've talked about. I wanted to just mention, as we're waiting for people to answer the poll, that there's large regional variation in how the COVID clinical assessment centers are working. And I think that's a little bit what we're reflecting, is being reflected in the chat and the Q&A. So you really do need to figure out, and help your patients to understand which centers they should be going to, and whether they should be calling the center first or your office. So I see sort of some other questions in the chat that really are kind of getting at that.
Tara, I just wanted to point out that there were some questions in the chat about just resources to help manage some of this, the stuff that we're dealing with, especially around mental health. And so I did post in the chat all of the structured psychotherapy referral links.
Perfect. We actually have a slide on that, and I'm going to go to that next after this. So Olivia, can we close out the poll? Can you display the results for us? Perfect. So there's no clear winner here. I think everybody, people think a large variety of these things are important. So I think the one that kind of stood out the most actually here, it seems, is clear processes to access treatment for eligible patients with COVID, which is interesting. So we'll have to bring that back in guidance on the management of long COVID, which there actually is. So David, maybe you could just repost in the chat the link to the Ontario Health guidance around long COVID, but then of course the balancing of in-person and virtual appointments. Next slide. So I don't know if you wanted to speak to this, Mekalai, but then I wanted to just talk about a couple of resources and get to some questions.
Sure, just briefly, and I think to Tara's point, really, it looks as though we really need that across the board support, and we really would like to continue to hear from you to really understand where exactly those gaps are. So just briefly at the OCFP, we really will continue to advocate on your behalf. We like to continue to provide tools and resources that can help as we are making this transition over the next few months. And of course, we'll continue to work with our partners as we implement this plan.
Next slide. So just wanted to highlight this. I think it's a really helpful resource. I use this all the time in my practice. As it's a 2-page handout that you can provide to patients and circle or highlight or verbally highlight the relevant resources, but it has not just the crisis support numbers, but also those free one-on-one counseling supports, as well as other information. So this one is about mental health and the resources for patients, and it's on the Ontario College website. Next slide. And when it comes to long COVID, I think Ontario Health has wonderful guidance, but I just wanted to remind people about the eConsult resources as well that are here. We talked about it last time, but there's eConsult platforms specifically for the post-acute COVID condition. So post-COVID condition, and please do use that if you do need additional support. eConsult is a terrific resource. Lots of people sharing some terrific resources as well, including some EMR specific resources in the chat, which is terrific. I'm going to end slides for a moment and maybe just go to a few questions. And Kate, I think there was a question just about accessing therapeutics for Indigenous populations, and then actually also for long-term care was the other one that I saw. So I wonder if you're able to address those.
Yeah, I want to thank whoever posed the question, because I meant to comment on that and did not. So in the tiers, one of the notable changes is that Indigenous populations were included as a risk factor, which in fact, being Indigenous, Black, or other BIPOC populations is not actually the risk. It's the fact that those populations have increased challenges of access, as well as are more likely to have some of the other risk factors. So that really contributes to worsening outcomes of disease. So in the new guidelines, what you'll see is that Indigenous, Black, other racialized populations have been removed out of the risk factors, but instead a statement is made about priority access for those populations, so that their criteria for the threshold for whether they're going to benefit from therapeutics is the same, but that because these are populations who have historically had difficulty accessing care for a variety of reasons, we should be prioritizing our rollout of these drugs and our access to these drugs to those populations. So there was a second half to your question that I've already forgotten, Tara.
No worries. Long-term care. So I think accessing therapeutics in long-term care. And I'll just say that for those in the GTA, last time around at our webinar, we did highlight long-term LTC Plus, or the LTC Plus phone number, as a way to access therapeutics for patients in long-term care. But I'm not familiar with sort of the process in other parts of the province.
Yeah, and so the location of the patient does not change their eligibility for therapeutics. So while we think about this as outpatient therapeutics, it's in fact therapeutics for mild disease. And our definition of mild disease in COVID is not requiring supplemental O2 over the baseline need. So these therapeutics would be appropriate and are available to patients who are in long-term care and other congregate facilities. They're also appropriate for hospitalized patients who, whether it's a nosocomial infection or it is an infection that comes from, that they're hospitalized for something else, but also have early COVID without an O2 need, would also qualify for therapeutics. And the access is through the same CACs. So the Paxlovid that is in the province is within those specific sites. And so you would still be making a referral to that for the virtual assessment that a patient who lives at a great distance might have as well. I think as Paxlovid becomes more widely available, we go to more general prescribing, that process will change. But right now it would be the same routes of access, but where the patient is doesn't matter. It's who the patient is that matters.
And they don't have to physically go to the clinical assessment center, Kate?
No, and that's true. As far as I know, at every CAC, that's true, because they're with only 12, I think we're actually 13 sites now in the province. Some of the territories that these sites cover are bigger than most provinces. So every site has had to work out a virtual assessment, and almost every site is shipping the drugs. Among other things, most of the CACs, a lot of the CACs are hospital-based, and hospitals don't dispense. So they've partnered with a community pharmacy that does the dispensing for them. Yeah, so in most cases, the drugs are couriered to where the patient is, and the patient is not physically going when it's Paxlovid. Obviously, Sutrivimab, you need to be in a site with infusion capacity. So in that case, you're either moving to an infusion site, or perhaps a dose of Sutrivimab is being sent to a location better. So in my rural community, for instance, they would ship the Sutrivimab to us and we would give it in our hospital ambulatory care department instead of the patient driving down to London.
Thanks, Kate. Allison, I have a question for you. I noticed that there were some questions in the Q&A, Allison, that related to prior infection. So how protective is prior infection? And in particular, I know that there were some questions, if you've got Omicron, the original variant BA.1, how protective is it against the newer strain BA.2?
So relative protection from vaccine doses and infection depends on which variant it is. So there's no one rule that tells you how to compare them exactly. An infection looks like it's somewhere between 1 dose and 2 doses of vaccine. So for some cross protection, having an infection is about the same as 2, and for others it looks like it's about 1 dose of vaccine. Again, so useful, but still means you should get vaccinated. For BA1 and BA2, of course, we don't have long-term data because they haven't been around for long enough, but the data we do have on reinfection comes from Denmark. Med-Archive paper, whose first author I can't remember at the moment, from about 10 days ago, that suggests that in the first sort of 45 days after a BA1 infection, people could get reinfected. So they had 1.1 million infections in Denmark, and 47 of them were reinfections from BA1 to BA2. So not impossible, but really low risk. And all of those infections were mild. It looked like there was a trend to milder infection when you got the second one. So if you've had a BA1 infection, at least in the short term, you're well protected against BA2. Longer term, probably not so well protected. And we know that now that the antibody you get from an Omicron infection may be pretty good against Omicron, but it's not very good against other variants. So once you've had an Omicron infection, you want to wait before you get your 3rd dose booster, but you still want to get your 3rd dose eventually.
Thanks so much, Allison. So lots of people sharing great resources in the chat. I'll just emphasize again the importance of knowing your local resources, because I think it was Pearl Yang, I may have gotten that wrong, who shared in the central region a great central resource for navigating and finding a COVID clinical assessment center. I think in terms of some of what we've talked about, Sid Feldman mentioned that the congregate care science table has just updated recommendations for therapeutics and congregate care, and that'll be being released soon. The focus is on what to do, not how to do it, as again, the how is going to vary by region. People talking about how can we identify high-risk patients in their electronic medical record. So David Dane's pointing out that Ontario MD had a webinar recently on that. And just to note that, of course, you can always reach out to an Ontario MD peer leader. And then David Kaplan pointing out that Ontario Health will be hosting a webinar this coming week around long COVID and the long COVID toolbar that's going to, or tool that's going to be integrated into TELUS PS. So I wonder, I'm just going to throw it to any of the other panelists. Were there any other items as you've been answering questions in the Q&A? Is there anything else that you want to highlight, Allison or Kate or David or Mekalai, that you've heard others bring up? No. And the absence of that, what I'm going to do is I'm just going to ask Olivia to bring back the slides to slide 40. So just a reminder that our panelists have answered a lot of the questions by typing in the Q&A. So take a look at some of those and we'll be summarizing those and sending them out. I did want to just, we talked about vaccinations and COVID vaccinations as one of the things that, of course, that we have a role to play in. And I just wanted to share as we close out some of the latest data for you, so we can think about where we need to kind of put our efforts. We can see here that the first dose coverage for 5 to 11 is still kind of stalled at the 54% range, is really only slowly come up of late. You know, I know some of us, I know in our own practice, our amazing team used the COVAX-on data to try and identify who hadn't been boosted in this group and actually reach out and call them. And that was only modestly successful. Many parents were reluctant and didn't even want to speak to a physician about it. But there were a few that changed their mind or who needed help booking. So, you know, every outreach does produce additional folks who get vaccinated. Next slide. Just go to the, and so here we see, you know, when we look at the 5 to 11 coverage, it's really, there's some geographic regions, especially in Toronto and Peel, that have lower vaccination rates. And so this is sort of pointing to the need for a hyper-local approach from our public health units. Next slide. And here we're seeing the booster data, and you know, just drawing attention to the 50 to 69 age group, and we see in that age group about 3/4, 74% have received their booster, and we know it's still really important for those 50 plus, and so that's an age group where we still could get better traction on that third dose. Next slide. So how are we doing when it comes to others? So these are the bottom part talks about some of the more priority populations, and we can see still that there's, you know, we can do better when it comes to getting third and fourth doses and those who are immunocompromised. So, and a reminder, of course, that people who are immunocompromised are eligible for a fourth dose because the 3 dose is considered the primary series for them. Next slide. And these are some more of our priority populations that I think that we have an opportunity to really reach out to. So these are many of our more vulnerable folks. I think many of us have done a good job of reaching out to those getting home care, for example. But you know, people with severe mental illness, addictions, newcomers, disabilities, those are people who are being left behind from that booster campaign. Next slide. And so that's where we can focus our attention. I also just wanted to remind people that I know vaccine conversations take a long time, but you can definitely take advantage of the VaxFacts clinic, where they take the time to have these conversations. And in particular, now they have partnered with the Black Physicians Associations of Ontario, specifically to provide phone counseling to members of the Black community who have experienced racism and have historical distrust because of that historical experience and present day experience. Next slide. So thank you to everybody though who contributed today. Huge thanks to our panelists, Allison McGeer, Kate Miller, Mekalai Kumanan, and David Kaplan, and David Kaplan's colleague Ivan Ewan, who also helped with some of the questions. Thank you for joining us and providing the latest evidence to everyone who attended. Thanks to all of you who attended and who continue to, power your way through what, has been an exhausting time, and continue to be there for your patients despite it all. Thanks to our back team who make these sessions happen, and a reminder that our next session, we're taking a little break for March break. So we're disrupting the every 2-week pattern, and we're going to be back in 3 weeks on Friday, March 25th. We'll send out that registration shortly, but in the meantime, please do check out the other sessions and resources that will be posted online. So thanks to all of you again, and stay safe and stay well. Take care.